Welcome to the Neuroscience Education Institute podcast. I'm Dr. Sabrina Siegel with NEI, and today my guest is Dr. Thomas Schwartz, professor and interim chair of the Department of Psychiatry at SUNY Upstate Medical University. And the topic that we're going to be addressing today is our focus is on the treatment modification in major depressive disorder. What are some of the challenges that clinicians face when it comes to dosing, switching, and augmentation? And with that, I'll go ahead and let Dr. Schwartz tell us a little bit more about this topic.
Yes, hello, and thanks for having this conversation with me. I get asked all the time, whether it's by my medical students, my psychiatry residents, junior colleagues, can I switch from drug A to drug B? Or drug B to drug C? How do I do it? Can I just switch right away? Do I got to take the drug away for several days? What do I do? What's safe? And I get that question a lot, and that's really the topic of today's episode, essentially. Is how do you do all this stuff?
Yeah.
So what I usually, tell folks, when in doubt, look things up. We can't possibly cover everything here in a session or
Right.
even a 1-hour lecture, but generally, when in doubt, look things up in a textbook, pull a package insert out from the FDA, and really, do things the smart way. So read about it. Outside of that, I generally tell people, if you're going to switch from, let's say, one antidepressant to another, if you really want to be safe and you really don't have time to look things up or things like that, slowly take away the first drug, wait a few days, and start the next drug. And that's called a washout. So you're really getting rid of the first drug. And to take it one step further, how do you know the drug's really out of your system or your patient's system?
That's a good question.
Sometimes you have to look up what we call the half-life.
Right.
And if you can look that up, if the half-life is a day or 24 hours, I usually say multiply that times 5. And after 5 times that half-life, or 5 days later, that drug's completely out of your patient's system. There's not going to be any drug interactions. That drug is completely gone. So the safest thing you can always do is slowly take the drug away over several days. That avoids any withdrawal. Wait a few days, or 5 times the half-life, whatever is the best for you, and then start the next drug. And that's the safest thing you can do. You don't have to look too many things up. And I think that's a reasonable approach. Now, what I have to say is not everybody does that anymore.
Right.
Your patient's in a hurry to get better.
Right.
We're in a hurry to get them better. And if we say, look, you need to wait 5 days, you need to wait 2 weeks.
Right.
People are like, but I'm on no medicine. And I'm going to get worse.
Right. I could see that.
So I don't think we use the washout much anymore.
Okay.
We'll lower the first drug while we start raising the second drug.
Right.
Some days we'll switch right from the first drug to the second drug all in one day. And to do that, it does get more complicated.
Okay.
So this is where you really need to do your homework. You do have to memorize some things as a clinician. You can certainly look these up every time with your patient, but that slows down your sessions.
Right.
So one rule of thumb would be, if you truly want to lower the first drug gradually, you don't have to get it down to 0. Get it down to just a couple milligrams. Get it down to a low dose, and you can start a really low dose of the next drug. This is, to me, I call this a true cross titration. The first drug is lowering, and as it gets really low, you start inching up the next drug. There's no wasted days on no medicine.
Right.
You save the patient 5 days, 7 days, and you can start the next treatment.
Okay.
Generally, I think that's pretty safe. The one area, maybe where it's not safe, we have some very long-acting medicines. So Prozac, fluoxetine, Celexa, citalopram, escitalopram, Lexapro. There are a couple drugs that have a half-life that are 3 days, 7 days. So even though I stop taking those drugs, they're still in my system 2 weeks later, 4 weeks later. So if you know which drugs are long half-life, I do really have to get them down to 0 or very, very low doses. And I got to hold it there, at least for a few days, before I start the next drug. So those long half-life drugs, there's only 4 or 5 of them that we use.
Right.
But once you know them, you know to delay the start of the next drug.
Okay.
You have to let enough drug burn out of the patient's system.
Right.
What's the risk?
Yeah.
You're on 2 drugs that are on fairly full doses, and if they're serotonin drugs, headaches, stomach aches, you feel like you have the flu, you can get serotonin syndrome or toxicity. That's rare, but again, you still don't want to do that to your patient. So I do think that true cross titration is what most psychopharmacologists will do. And we don't want to give 4, 5, 14, 21 days of nothing.
Right.
So I do think that's the most common strategy. And after that, could you really switch from drug A to drug B? So I quit the first drug now, and tomorrow morning I have my patient start the next drug. You can. So the drugs have to be very similar.
Okay.
So we have the antidepressants called the SSRIs.
Right.
And they raise serotonin. That's what they do. It's a pretty simple mechanism. So I could quit the first SSRI today and start the next one tomorrow. They're like replacing each other.
Right. Okay.
So you won't be serotonin toxic, meaning you're not on 2 drugs on the same day, and you won't go into serotonin withdrawal.
Right.
So if the drug mechanisms are very similar, you can get away with that.
Okay.
Again, the warning would be drugs like Prozac, Lexapro, and Celexa, the longer half-life drugs. Again, I would be lowering the first drug for a few days before making that switch.
Right.
But outside of that, you can make a swap from SSRI to SSRI. And the SNRIs are somewhat similar. They're serotonin and norepinephrine drugs. You can make those switches. So there are some drugs that in the antidepressant family where you can get away with it. What does that mean? You have to memorize which drug is in which family and what half-life they have. So it gets busier and it's harder to do, but some drugs you can switch overnight. So if you're getting a sense there's an art to this more than a science, yeah, there is. So I always joke you can talk to 100 psychiatrists, for example, and a third of us will do a straightforward switch, day 1 to day 2. A third of us might do a washout, and the other third will do these cross titrations. There's not a rhyme or reason necessarily.
Okay.
It's what we get used to in our practices. And the other one is you have to memorize a lot of things.
Right.
Half-lives and what drug families they're in, and then you really could make it very specific. Which 2 drugs are you talking about?
Okay.
But it takes a lot of work.
So at this point, there isn't a strong consensus in the field about how to switch in that type. Okay.
No, I really think there's not a consensus, and we're just talking antidepressants.
Yeah.
We didn't talk about antiemetics or the schizophrenia medicines.
Right.
And I think, again, the same practices would apply, but you will find a lot of prescribers will use different techniques. I even remember some of the schizophrenia medicines, the antipsychotics, actually looked at things like what if you do a direct switch versus a true cross titration, and it didn't matter. So sometimes it doesn't matter, and it's easy.
Right.
But not every drug have done those kind of trials.
Okay.
But the same principles, I think, would apply to almost everything we do.
To everything. Okay. What would you say is a particular challenge that comes across when you do need to switch or modify an antidepressant treatment? Well, let's just talk about antidepressants.
Yeah.
Or what would you say is maybe perhaps the biggest challenge that you have?
So I think if you don't use a washout, which again is getting rid of drug 1 completely, so the patient has nothing in their system. If you're doing any kind of switch where the first drug is being lowered while the next drug is being increased, what if they get side effects?
Yeah.
What if you get headaches? Which drug is causing it?
Right.
What if they get nausea?
Right.
Sometimes we don't know.
Right.
A lot of these drugs share the same side effect profile. And I think where we get stuck is we have to guess.
Right.
So you have nausea. Does that mean, do I lower the new drug, or is it withdrawal and I raise the last drug? And sometimes we really don't know, and that's a hard discussion to have with your patient.
Right.
And when I have to do this, I'll have to tell them, I'm going to guess here.
Right.
Given my 20 years of experience, I think the nausea is related to withdrawal.
Right.
So I'm actually going to push up your old drug a little bit.
Okay.
And, and we'll see how it goes. If it gets worse, then I'm wrong. We're going to go to plan B.
Right.
And then we're going to notice it's your new drug and we'll lower it.
Right.
So I think you just have to be honest with your patients when you're stuck in the middle of 2 different drugs getting side effects.
That's a good point.
Yeah.
So then if a washout is something that a clinician would like to do you have any advice as to how to address that with their patients? With the concern that you brought up before, that the patient might feel almost anxiety or fear that they've stopped their medication. Is there a way to talk to your patient to explain it in such a way that it would at least be comforting in some respect?
So I do think there's a fair amount of that concern. I'm used to being on a medicine, even though the last medicine wasn't working perfectly, it might have been working a little bit.
Yeah.
Now I'll be naked without any medicine. So I think Part is just realizing and having that discussion that, this certainly could happen. You could
Right.
get worse. I would also say I doubt it. There is still some of that drug lingering in your
Right,
system.
okay. That's
Remember
good.
how your brain takes a few weeks for the antidepressant to
Right.
kick in?
Okay.
It also takes a few weeks for it to
Okay.
drift away. So even though the drug is gone, your
Yeah.
brain still thinks it's there.
Right.
So I think you can explain that to your patients. I might bring the patient in more often.
Okay.
I might call their therapist if I'm not doing the
Okay.
therapy and say, can we book an extra session or two?
Right. Okay.
So I do think you can build psychosocial support around the person if you're going to wash them out. And a lot of patients are on what I call polypharmacy. They're on 2 or 3
Right.
medicines. I may just be taking the antidepressant away, but they still have their sleeping pill. They still have their
Right.
anxiety medicine.
Right.
So those things won't get hurt.
Yeah.
So I do think that every patient is different, but these are some of the ways we would explain if you're going to do a washout. You might get into trouble, but I usually don't see that.
Okay.
And here's what we're going to do to try to keep you safe and at least doing okay.
Right.
And that seems to be helpful.
Okay. Well, thank you so much. Thank you for joining us, Dr. Schwartz, and we hope you've enjoyed this episode, and tune in here for another episode of the NEI podcast.